Hello, and thank you for taking the time to learn about the one anastomosis gastric bypass, also called the mini gastric bypass. If you're watching this, you or someone you care about may be considering weight loss surgery, and my goal is to give you a clear, honest, data-driven understanding of this operation. One anastomosis gastric bypass is now the third most commonly performed bariatric procedure worldwide, behind the sleeve gastrectomy and the Roux-en-Y gastric bypass. It is recognized by both IFSO and the ASMBS as a safe and effective metabolic operation. The concept is straightforward. Take a proven metabolic power of the gastric bypass and simplify it. One anastomotic connection instead of two. Shorter operative time, fewer potential complications, similar weight loss and metabolic results. But simpler does not mean identical. There are important differences between this operation and the Roux-en-Y, and understanding those differences is how you make the right decision. Throughout this video, I will compare the two procedures directly so you can see exactly where they overlap and where they diverge. Let's get into it. So who qualifies? Current ASMBS guidelines recommend bariatric surgery for BMI 35 or higher, regardless of other conditions, or BMI between 30 and 35 with metabolic diseases like type 2 diabetes, hypertension, high blood pressure, sleep apnea, and for patients of Asian descent, generally BMI of 27 or above. One anastomosis gastric bypass is especially well suited for patients with a very high BMI, patients with type 2 diabetes who would benefit from strong metabolic effects, and patients with weight regain after a prior sleeve or band. There are specific contraindications unique to this procedure. Expert consensus states that one anastomosis gastric bypass should not be offered to patients with severe GERD or reflux, with grade C or D esophagitis, Barrett's esophagus, or intestinal metaplasia of the stomach. For those patients, the Roux-en-Y gastric bypass is the operation of choice because the Roux-en-Y gastric configuration completely diverts bile away from the esophagus. Both operations start the same way. We create a small stomach pouch and connect it to the small intestine, bypassing most of the stomach and the duodenum. The critical difference is in the plumbing. In a Roux-en-Y gastric bypass, the small intestine is divided and rearranged into two separate channels connected by two intestinal connections. A food channel called the Roux limb carries the food from the pouch down. A separate biliopancreatic channel carries bile and the digestive enzymes. The two channels meet downstream at a second connection called the jejuno-jejunostomy. This creates a Y-shaped configuration with three distinct limbs and two anastomoses. In a one anastomosis gastric bypass, we skip all that complexity. We create a longer, narrower gastric pouch, about 12 to 18 centimeters, guided by a 36 to 40 French bougie. Then we measure 150 to 250 centimeters of jejunum from the ligament detritus and bring that single loop of intestine up to the pouch. One connection, one anastomosis, that's it. Food travels from the pouch through the single anastomosis and down the intestine. Bile and pancreatic enzymes travel through the bypassed limb into the loop from the other direction, mixing with the food downstream. The result? There's one fewer intestinal connection, one fewer mesenteric defect to close, and significantly shorter operative time. In Y-Omega, a randomized trial, operative time averaged 85 minutes for the OAGB versus 111 minutes for the Roux-en-Y gastric bypass. In the MBSA-equipped national database of over 47,000 patients, operative time was 99 minutes versus 132 minutes. In a single-center comparative study, it was 80 versus 125 minutes. Most patients stay 1 to 2 nights in the hospital and return to normal activities within 2 to 4 weeks. So how does it work? Both operations work through the same core mechanisms: restriction, hormonal reprogramming, and malabsorption. But there's a difference in degree. The small pouch limits how much you can eat. Early on, meals may be just a few tablespoons, eventually increasing to about half a cup to a cup. The hormonal changes are where the real power is. Bypassing the stomach and the duodenum delivers food rapidly into the jejunum, triggering a surge of GLP-1 and PYY, the hormones that tell your brain you're full. These hormonal changes improve insulin sensitivity, stimulate insulin secretion, often within days after surgery, before significant weight loss has occurred. One important difference is that the longer gastric pouch in the one anastomosis gastric bypass slows the rate at which food enters the intestine compared to the Roux-en-Y. This is why dumping syndrome is significantly less common. In the Y-Omega trial, at 5 years, early dumping syndrome occurred in 16% of OAGB patients versus 36% of Roux-en-Y patients. A separate study of 266 patients found dumping syndrome in about 21% after OAGB compared to 40 to 70% after Roux-en-Y in the literature. The malabsorptive component is somewhat greater with the 1 anastomosis gastric bypass because the biliopancreatic limb is typically longer, 150 to 250 centimeters, as compared to 50 to 100 centimeters in the standard Roux-en-Y. This means more fat malabsorption, which contributes to weight loss. But it also means more diarrhea and statorrhea, which is fat malabsorption, particularly in the first year. So what are the results in terms of weight loss and health improvements? The data are now strong, with 10-year outcomes available in multiple centers. Weight loss is comparable to or slightly greater than the Roux-en-Y gastric bypass. A meta-analysis of 12 randomized controlled trials with 904 patients found that excess weight loss was significantly higher after 1 anastomosis gastric bypass at 12 months, with no significant difference at 6, 24, or 60 months. The Y-Omega trial found the total weight loss of 37.1% for OAGB versus 35.4% for Roux-en-Y at 2 years, confirming non-inferiority. A systemic review of studies with at least 10 years of follow-up, comprising of 1,750 patients, found weighted mean total weight loss of 31.1% at 10 years. A single-center study of 385 patients found 33% and a total weight loss of 33% at 10 years. A 10-year comparative study of 940 patients found that 1 anastomosis gastric bypass had significantly greater weight loss than the Roux-en-Y at 10 years. A systematic review and meta-analysis of over 19,000 patients with a mean follow-up of 6.7 years found 75% excess weight loss at 5 years, increasing to 77% beyond 5 years. Health improvements are dramatic and comparable to Roux-en-Y. Diabetes remission rates are between 71 and 90% at 10 years. The Y-Omega trial found that 1 anastomosis gastric bypass reduced hemoglobin A1C to a greater degree than Roux-en-Y at 2 years. Sleep apnea resolves in approximately 89% of patients. Hypertension improves in 57 to 85%. Dyslipidemia remission was significantly higher after OAGB in one meta-analysis study of randomized trials. These improvements translate into longer life. Bariatric surgery overall is associated with approximately a 50% reduction in all-cause mortality and a median life expectancy gain of about 6 years. Risks and complications, and this is where the two procedures differ the most. Overall safety is excellent. Mortality is 0.03 to 0.1% in the MBSA-QIP database. 1 anastomosis gastric bypass had significantly lower rates of overall complications, readmission, and reoperation compared to the Roux-en-Y at 30 days. But the long-term complication profiles where the two procedures diverge the most, and this is what you need to understand. Bile reflux. This is the central controversy. Because 1 anastomosis gastric bypass uses a loop configuration rather than a Roux-en-Y configuration, bile can theoretically travel backwards through the anastomosis into the pouch and esophagus. In a meta-analysis of 87 studies with over 27,000 patients, they found a 6% rate of new onset reflux, 15% esophagitis, and 1% Barrett's esophagus after a 1 anastomosis gastric bypass. In a prospective study with objective testing, they found bile in the pouch 48% of the time, and 38% of the time they found esophagitis, with Barrett's 6% of the time. That was at 4 years. And this was even in asymptomatic patients. By comparison, Roux-en-Y eliminates bile reflux entirely. Reflux improves in approximately 97% of Roux patients. And this is the single biggest advantage the Roux-en-Y has over the 1 anastomosis bypass. Marginal ulcers. In a meta-analysis of over 25,000 patients, they found a 2% incidence in a 1 anastomosis gastric bypass. A separate meta-analysis of randomized trials found marginal ulcers were about 2.7 times more common after OAGB than Roux-en-Y gastric bypass. However, both rates were lower than 10 to 16% in some of the Roux series. Most are treated with proton pump inhibitors like omeprazole. Internal hernias, this is an advantage for the OAGB because there's only one mesenteric defect instead of 2 or 3. Internal hernias are less common. In a large series of about 3,300 patients, they found a 2.8% rate in a 10-year comparative study. Internal hernias were significantly more common after Roux-en-Y gastric bypass. Nutritional complications. The longer biliopancreatic limb means more malabsorption. In the Y-Omega trial, serious adverse nutritional events occurred in 7.8% in 1 anastomosis patients and 3.4% requiring conversion to Roux-en-Y for malnutrition. Vitamin D deficiency is more prevalent after 1 anastomosis gastric bypass. Fat-soluble vitamin monitoring is also essential. Dumping syndrome, significantly less common as discussed. This is an advantage for the 1 anastomosis bypass. Strictures, less than 1%, lower than after Roux-en-Y. Conversion to Roux-en-Y. In the Y-Omega trial, 8% of 1 anastomosis bypass patients were converted to Roux-en-Y by 5 years, primarily for reflux, ulcers, or both. Overall, 3 to 5% of patients require conversion or revisional therapy. These two operations produce similar weight loss and similar metabolic effects. The difference are in the details. 1 anastomosis gastric bypass advantages: shorter operative time, simpler technique, fewer early complications, lower internal hernia risk, lower dumping syndrome, and lower stricture rate, as well as some studies showing better diabetes resolution. With the Roux-en-Y gastric bypass advantages, it eliminates bile reflux, better reflux protection, lower marginal ulcer risk, less malabsorption, less nutritional complications, and it has a longer track record with about 50 years of data. If you have significant reflux, esophagitis, or Barrett's esophagus, the Roux-en-Y is the right choice. If you don't have reflux and you want a simpler operation with comparable or potentially greater metabolic power, the 1 anastomosis gastric bypass is an excellent option. Life after 1 anastomosis gastric bypass follows the same principles as life after Roux-en-Y. Diet progression happens in stages: clear liquids, purees, soft foods, and regular food by 6 to 8 weeks. Protein first at every meal. Eat at least 60 to 80 grams per day. No drinking with meals, no carbonation, no sugar. Stay hydrated with at least 64 ounces of water per day. Vitamins are lifelong and non-negotiable. A bariatric multivitamin, calcium citrate, vitamin D, B12, and iron. Because of the longer biliopancreatic limb, fat-soluble vitamin monitoring is especially important. Blood work every 3 to 6 months the first year, and then at least annually for life. Regular endoscopic surveillance is recommended given the bile reflux concern. This is a monitoring requirement that does not apply to Roux-en-Y patients. Exercise matters. Start walking immediately, build to 150 minutes per week. Follow-up is non-negotiable. The patients who stay connected with their surgical team get the best long-term results. 1 anastomosis gastric bypass is a powerful, effective metabolic operation. It delivers the metabolic benefits of a gastric bypass with a simpler, faster technique. The weight loss is excellent, the diabetes remission is excellent, and the safety profile is excellent. The trade-off is bile reflux. That's the honest answer. The Roux-en-Y eliminates it. The 1 anastomosis gastric bypass does not. For patients without reflux, that trade-off is very reasonable. For patients with reflux, it may not be. Choosing the right operation is individualized. It depends on your BMI, your reflux status, your metabolic disease, your anatomy, and your goals. That decision should be made together with your surgeon based on a thorough evaluation. If you're considering this surgery, the next step is a consultation. We will do a full workup and help you determine whether 1 anastomosis gastric bypass, Roux-en-Y gastric bypass, another procedure is the right fit for you. Thank you for watching. Stay for the next video about duodenal switch procedures. Real science, real surgery, real results.